برحب بالجميع طبعا. Welcome to the second day of our free online event, the conduct in celebration of Patient Safety Awareness Week 2021, with partnership from our expert CPPS-tricks. Take opportunity to conduct this online event, which aim to raising awareness to patient safety and play a role in culture transformation toward medical care to be free from harm, to provide a reliable care, meet our patient needs in our community. In Patient Safety Awareness Week Conference 2021, we are excited to welcome all to this biggest free online conference in Middle East that hosted by CPPS-tricks, where we will hear as a partner from our expert panelists in the Middle East, who will share their experience and priceless knowledge with us in a truly engaging and powerful discussion. Thanks for all who care to join us. Wishing you the best, rich, useful time. Today, inshallah, we will hear to Dr. SUZAN Alowesie. Dr. SUZAN Alowesie is a registered pharmacist with more than 15 years experience of managing quality and patient safety in fast-paced hospital environments, with a successive track record encompassing medication safety, performance improvement, facility accreditation, patient safety and risk management. Dr. SUZAN holding a master degree in project management from Salford University, United Kingdom. Also, Dr. SUZAN is a medication management accredited surveyor with CPAHI. Dr. SUZAN holds different certificates in quality science as CBHQ, CBHRM, certified Lean Six Sigma Green Belt, and Team Steps Master Trainer. Currently, Dr. SUZAN is a director of quality and patient safety at Dr. Muhammad Al Faqih Hospital in Riyadh. Dr. SUZAN also participated in a couple of patient safety researches in affiliation with King Abdullah International Medical Research Center. She was a speaker in many national and international conferences. Welcome, Dr. SUZAN. تفضلي يا دكتورة.
Thank you, Dr. Abdul Fatouh. Assalamu alaikum wa rahmatullahi wa barakatuh.
وعليكم
Bismillah
السلام.
ar-Rahman ar-Rahim. Wassalatu wassalamu ala Rasulillah wa ala alihi wa sahbihi ajma'in. Thank you for the generous introduction. It's my pleasure to be part of your annual conference in Patient Safety Awareness Week. Thank you, Dr. Abdul Fatouh, for all your efforts and for the organizing committee for having this week free for all to get the benefits out of it. And I hope that my presentation for today, inshallah, will add value to all who are attending. It's my pleasure to introduce to you a very interesting topic in medication safety under the title Safe Management and Handling of Hazardous Medications. It's a very vital topic indeed when we talk about hazardous medications, and whenever we talk about hazardous.
معلش
Can
يا
you hear me?
دكتورة. ايوه معاكي، بس ممكن تشير السلايدز من عندك؟
I'm sorry. Okay.
معلش تحت امرك.
Okay, I'm going to share my slides now. Okay, can you see my slides now?
ايوه حدان حالا. ايوه اوكي خلاص يا دكتورة. اعملي
Okay,
شوينج
great.
بس. ايوه خلاص كده اوكي.
Okay, great. Okay, so once again, so my topic is under the medication safety series under the title Safe Management and Handling of Hazardous Medication. As I said before, this is a very important topic, and whenever we talk about hazardous medication, what comes to people's mind is the chemotherapy and cytotoxic agents. And hopefully by the end of this presentation, you will figure out that the picture is much broader and deeper than just when we talk about cytotoxic medication or chemotherapy. They are all around you whenever you work in pharmacy or the across hospital units, and you have to be cautious whenever you identify them and deal with them, handling them, administer them, prescribe them, crush them, or even administering it to the patients. They pose risk to healthcare providers' life, and therefore we need to increase staff safety in this aspect. So this week, Awareness Week is not only talking about patient safety, on the same token, we have to take care also about staff safety at the same level. So my objectives for this presentation at the conclusion of this educational activity, I'm hoping that the participant will be able to define the 3 categories of hazardous drug on the what we call NIOSH hazardous drug list. Moreover, we will be able to understand the process of assessment of risk of hazardous drugs in your facility. How to do the risk assessment. Are all hazardous drugs carries the same kind or level of toxicity? And how can we deal with them? Number 3, we will link our practices to national and international standards at the local environment. For example, for people who are practicing in Saudi Arabia, we have an accreditation body called CPPS, the Central Board of Accreditation in Healthcare Institution. We have the international accreditation, the very famous one, JCI, the USP 800, which is the chapter specific and dedicated for talking about hazardous medication management to guide best and safe management practices of hazardous drug. Lastly, we will share some examples of best practices that guide safe management and handling of hazardous drug from different institutions. As you know, if we keep on talking theoretical and abstract, it will not stick to our mind and it might not add much value. So we'll try to bring out some examples of different institutions and how they have dealt with such hazardous category of medications. Before start, I have a poll questions. It is not linked to a statistics kind. I just need you to think about it between yourself. And I'll share the correct answer. So hopefully you can reflect on that. So my question says, for what are the non-oncologic use of methotrexate? Everybody knows methotrexate, a hazardous drug with a high level of cytotoxicity used widely in chemotherapy regimen. I'll just give you a few seconds trying to solve this question and reflect on it. Is among non-oncological use of methotrexate, is it used for rheumatoid arthritis? Is it used for psoriasis, ectopic pregnancy, all of the above, or A and C? Okay, so the correct answer is all of the above. So if you have answered the letter D, then you get the correct answer. Methotrexate is, as I said, is a very famous cytotoxic agent, but what some of healthcare providers might not know about it, that it also can be used for another non-oncological use, such as in rheumatoid arthritis, psoriasis, and ectopic pregnancy. I'm going to reflect on why I brought up this example, especially in institutions that they don't have a chemotherapy agents among their scope of services, that they think that they are safe from these categories of medication as they don't deal with it. My second question, under USP chapter number 800, it promotes for safety practices related to number 1, patient safety, B, worker safety, C, environmental protection, D, all of the above. So what do you think is the correct answer that covers 800 chapter, USP 800 chapter? Okay, so if your answer is letter D, it deals with all aspects related to patient, worker, and environmental safety. That's why it's very important for any healthcare worker, whether a pharmacist, a physician, a nurse, to know very well about the provision of this chapter and what it articulates in order to protect their patients, to protect themselves, and to protect their environment. So this is what we call the hazardous drug life cycle. And when we talk about precautions to protect ourselves, our patients, and our environment from the hazardness of drug, of hazardous drug, it's not only at the point of preparation or administration. We have all to be careful, starting from the point of receiving those medications. How do we transport them? How do we store them? What is the precautions and the steps when we compound them? How do we transport it to patient after preparation and compounding it? How do we administer them? And lastly, how do we discard them? So at each and every step of the life cycle of those hazardous drugs, it carries different kind of toxicity and hazardness that we have to be well aware of it. Even for our colleagues that they work in the warehouse, for the laborer who transport these medications, they have to be informed, trained, get oriented to the hazardness of these drugs and providing them with the necessary precautions in order to protect themselves, their colleagues, and their environment. So why do we need to care about handling hazardous drugs safely? What are the toxicity related to them? Here I brought some research studies and some real case scenarios about information and statistics related to those medications. Antineoplastic drugs exposure was associated with twofold increased risk of spontaneous abortion in pregnant women. Literature review of 18 publications suggest occupational exposure to antineoplastic raise risk of congenital anomalies, miscarriages, and subfertility. Moreover, dealing with hazardous drug significantly increase risk of leukemia among oncology nurses in Danish Cancer Registry over 40 years period. High levels of genetic aberrations, especially in relation to chromosomes 5 and 7 in healthcare worker linked to secondary cancers, especially with alkylating agents. So dealing with those medication is not a joke. It's something that we have to be very careful about it, even for male and male, female and male at the same level of toxicity. So let's take some background how we came up with those category of medications and place them in this special category and titled them as hazardous or cytotoxic drug. It firstly started in 1940s, where cytotoxic drugs were developed from mustard gas used in World War I. Clinicians used only gloves, masks, and gowns for protecting themselves against dealing with those agents. Later on in late 1970s, especially in particular in 1979, the University of Helsinki reported traces of chemotherapeutic agents found in the urine of nurses who administer those medications to oncology patients. In early 1980s, nurses reported they were experiencing side effects similar to those of chemotherapy patients. Results from these studies showed mutagenic activity in personnel working in horizontal laminar flow hoods in the preparation stage. Based on these findings, new vertical laminar air flow hoods called the Biological Safety Cabinets, BSC. If we have pharmacists among the audience, they will very well familiar with the BSC, the Biological Safety Cabinets for preparation of oncology medication. They were start to be implemented in 1980s. This is how it looks like. Then in 1990s and 2000s, where we call it the revolution of patient safety era, studies consistently reported similar findings, and it was clear that regardless of employee skill and carefulness, contamination was still a problem. Studies found contamination appeared in 75% of samples taken from pharmacy areas, from the laminar hoods, floor of the preparation area of pharmacist shoes and gloves. Contamination also appeared in 65% of the administration area, on the floor around the patient's chair, on the office telephone, the patient's bed, and in the preparation trays. So those contamination and traces were everywhere. And that's why later on, the patient safety science started to talk about protecting patients and safety and workers and environment, and what are the standard measures that we need to follow to protect ourselves. In 1996, because of the reoccurring finding in different hospitals, different institutions with different healthcare workers, the OSHA, which is the Occupational Safety Hazardous, published the following statement on the potential hazards of handling antineoplastic and hazardous drug. It says, preparation, administration, and disposal of hazardous drug may expose pharmacists, nurses, physicians, and other healthcare workers to potentially significant workplace levels of these chemicals. Today, studies continue to find hazardous drug contamination throughout pharmacy and nursing setting and in the urine of oncology staff, including those not directly involved in the preparation process. So you could contaminate if there is no appropriate preparation practices or administration practices. We could contaminate all the areas around. So what are those medications and how they came up, collated all in under this unified category? Hazardous drugs include those used for cancer chemotherapy, antiviral drugs, hormones. So do you imagine, for example, that estrogen is a hazardous drug? Some bioengineered drugs and other miscellaneous drug. The NIOSH definition that was appeared in 19 and published in 1990 of hazardous drug are drugs that exhibit one or more of the following 6 characteristics in humans or animals. They could cause carcinogenicity, genotoxins, teratogenicity, reproductive toxicity, organ toxicity at low doses, structure or toxicity similar to other drugs classified as hazardous drug. So any of those medication, if they exhibit one or more of those characteristics, they will be leveled under the definition of hazardous drugs. Simply, these are drugs that can cause harm to staff. So how NIOSH classified those medication, and they came up to discovery of the toxicity of these drugs. NIOSH systematic approach to evaluating hazardness potential of a drug includes they review the FDA databases on a monthly basis, and they review the side effects, for example, that is published by the FDA. And if they identified any report that talks about those 6 characteristics, either genotoxicity or carcinogenicity, so automatically they classified this medication under the category, and they tend to update their list on a regular basis. They also review preclinical and clinical information provided by manufacturers themselves, the package inserts, on a monthly basis. For example, drugs with a new safety labeling changes, new boxed warning, black boxes, new pregnancy and lactation labeling information. They assess, integrate, and synthesize evidence from human, animal, and in vitro studies of drug toxicity, which we call it the post-marketing experience. They also study, when available, published peer-reviewed scientific literature about the hazards potential of a particular drug. NIOSH also may receive a request from an interested party to add drug to the list. They get also information from the WHO, International Agency of Research or Cancer. So whenever they get a any clue or an alert from any of those sources of information about any potential toxicity or hazardness of any drug, they automatically list it under that list. And this is the process. I'm not going to take you through that complex slide, but it shows you simply by steps how, by studying the medications, how NIOSH is identifying certain drugs, how it put it under the research study until it finally could conclude that this drug could be listed into the hazardous medication list or not. Now, remember the three groups that NIOSH has classified those medication under. They classified hazardous drug into three groups, and there is a purpose for that. We're going to talk about it momentarily. The first group classified by NIOSH is called the antineoplastic drug, the chemotherapy. They may also pose a reproductive risk for susceptible populations. So those classification is not based on the level of toxicity. It has nothing to do with that. They just want to classify it as per category, scientific category or therapeutic category. So the first group is called the antineoplastic that has a reproductive risk. Group 2 is called the non-antineoplastic drugs. It's not a chemotherapeutic agent, but it meets one or more of the NIOSH criteria for hazardous drug, the 6 criteria that we have talked about. Some of these drugs may pose a reproductive risk. So they have distinguished it with font color for susceptible population. And this exists in table 2 under NIOSH list. Group 3 of hazardous medication are drugs that primarily pose a reproductive risk to men and women who are actively trying to conceive and women who are pregnant or breastfeeding. Because these agents present in breast milk. So we have 3 categories exist in table 1, table 2, and table 3. And if you Google the hazardous drug list under NIOSH, you will find the tables. You will find the medication classified into the generic drug name, the formulation that it exists under, and what is the rationale that NIOSH has classified this medication or placed it under the hazardous drug list. For example, for bifigazumab, it carries a reproductive toxicity, teratogenicity, and other developmental toxicity. It has an ovarian failure manifestation in patients in clinical trial, embryo fetal toxicity in rabbits, and so on and so forth. This is just a snapshot from those tables. If you go to those tables, you can read through alphabetically how these medications are placed into the 3 tables that we have talked about and what are the rationale for their toxicity. Also, you can find in the same table under NIOSH, under table 5, they talked about the personal protective equipment and engineering controls for workers with hazardous drug in healthcare settings. How should you protect yourself? What should we wear when we dispense those medication or administer medication? Of course, there are different level of hazards. When I'm administering a medication, it's different when it's been prescribed or dispensed or crushed. So it's not the same. The same level of PPE or personal protective equipment necessity for all of them. For example, if the formulation for all type of hazardous drug, if the activity is receiving, unpacking, and placing in storage, no single glove can be used. Double chemotherapy gloves, no need. Only single glove can be used unless spills occur. Protective gown, yes, we need to have a protective gown when spills and leak occur. Do we need an eye and face protection? No. Do we need a respiratory protection? Yes, when spills and leaks occur only. Do we need a ventilated engineering control? This is the biological safety cabinet that I have showed you the picture. No need for that. If you are dealing with tablet or capsule, solid dosage form, So upon administration from unit dose package, do we need a double chemotherapy? No, only single glove can be used. Do we need a protective gown? No. Eye face protection? No. Respiratory protection? No. Ventilate? Of course, no, because we're dealing with, a simple tablet that I'm going to unpack it from its foil and give it to the patient. However, when we deal for example, with tablet for cutting or crushing, I need to wear a double chemotherapy gloves. I need to wear a protective gown. No need for eye or face protection. I need to wear respiratory protection if not done in a controlled device. And I need to prepare it under biological safety cabinet. Maybe not a lot of you aware that I need to prepare if I need to crush or grind hazardous drug tablets such as warfarin or phenytoin, or dissolve it in a cup of water, that I need to wear the following personal protective equipment. So dealing with them at different stages of preparation is not the same. Oftentimes, as a surveyor, when I go and audit hospitals sometimes, and I ask them for their policies related to hazardous medication precautions, I find a statement all across that we need to wear double gloves, we need to wear gowns and goggles, regardless of the stage of preparation. Well, that's a waste. This is inefficiency. You have to do always what we call a risk assessment. So if there is no direct risk from these medication, such as when I administer a tablet as a whole to the patient without having to cut it or grind it, you don't have to wear a personal protective equipment. Single glove is enough. But when I am preparing a methotrexate from a vial, for example, definitely I have to prepare it under a biological safety cabinet. I have to wear a protective gown, a special gown that is specifically designed for chemotherapy and cytotoxic agent that is non-penetrable. So again, my advice is you have to go to that link, please. And you have to Google the NIOSH list precautions to deal with different kind of medication. And if you need further resources, I'm happy to send it to Dr. Abel Fatouh to share with you the different level of protection for different formulation and for different activities. But the key word here, or the key statement that I advise you, is always to do risk assessment. This is how it looks like, the NIOSH list of antineoplastic and other hazardous drug in healthcare setting, 2016. I'm not sure if we have more updated one. Maybe I'm not yet updated, but as far as I know, that's the most updated one. If you Google, if you don't have also access to that, it'll be my happy to share it also with Dr. Abel Fatouh, so he can publish it across. So what you need to do is you need to go back to your formulary, especially the pharmacists, identify among your formulary medications, what are the medications listed that are matching with the NIOSH table, that I can list them as a hazardous, and then I have to put forward specific precautions on how to deal with each one of those medication under different activities. In Saudi Arabia, we have سباهي, المركز السعودي لاعتماد المنشآت الصحية. I think in Egypt we have, I think Gahira, or I'm not sure about Gahar. Right. Congratulations for your new accreditation body there. So more or less you will find the standards similar among different accreditation body. So in Saudi Arabia, Sibahi, we have different standards that is linked with hazardous medication. For example, medication management 5.1 standard describing that there should be a written plan for managing of high alert medication and hazardous chemicals. MM 5.3, the hospital plan for managing high alert medication, hazardous medication is implemented. Medication management standard number 28, the hospital has a system for safe preparation of sterile chemotherapy compounding preparation. Standard MM 28.1, there is a policy and procedure on preparation and handling of sterile compounding chemotherapy. So as you can see, the standards clearly needs to see institution compliance with dealing with hazardous and chemotherapy medications. Similarly, for the international accreditation bodies such as JCI, in their FMS number 5, they requested that the hospital has a program, for the inventory, handling, storage, and use of hazardous material and waste. FMS, the Facility Management and Safety number 11.1, staff members are trained, knowledgeable about the roles in hospitals program for fire safety, security, hazardous material, and emergencies. On July 1st, 2018, and then it was postponed to December 1, 2019, the USP Chapter 800 was mandatory, and it applies to all healthcare personnel that handle hazardous drug. It took really a little while before they approved this chapter and make it into effect. It was really complex, complicated, and the USP membership and organizing committee was trying hard to put everybody talks the same language and to put standard that could apply to internationally to everyone. That's why it took a little while before it's published, released, and become into effect. They included all NIOSH listed hazardous drug. More information on closed system drug transfer devices also added. They had some information on robotics in pharmacy area deal with hazardous drug and the requirement for engineering control. And here we're talking about the biological safety cabinet. Let me give you some break with another poll question. What are the potential routes for worker exposure to hazardous drug? If you're dealing with any of those hazardous drug, where do you think is the bad effect or the potential on you as a healthcare worker? Is it due to its dermal absorption, letter A, B, due to potential for inhalation, letter C, potential for ingestion, or percutaneous injury? Where do you think is the potential hazardness of those drug effect? Well, if your answer is all of the above.
All the above.
Yeah, great, excellent. So we have to be careful, including all these kind of sources of exposure to hazardous drug. So how to develop your own list? Now you're aware about the hazardness of these medication, and we have to be very careful. As I said, the key word here is to do risk assessment. If you're working with an outpatient pharmacy, for example, where you don't prepare medications, you don't touch them, you just dispense them in their outside package, it's different when you are dealing in the inpatient pharmacy. You are preparing them, you are withdrawing those medication into a syringe. So you have to do this kind of risk assessment. So where should I start? I should start by doing a thorough search in all areas and my formulary to identify what are those medications. I need to compare my formulary to the NIOSH list and reconcile what are the medications that are similar to the list in NIOSH. Documentation of information about the location, types, quantities of those hazardous medication, and waste being stored. So in every area, you have to list down what are the floor stock storage of those particular areas. They have to be well aware and informed about the hazards around them. You have to assess the effect to a worker handling a drug identified on the list. Depends on exposure factors unique to a particular work settings. So a physician dealing with those medication is different from a pharmacist, is going to be different from a nurse. In some settings, when we deal, for example, with methotrexate, most of the time for non-oncologic purposes, physicians are the one who are administering methotrexate in case of ectopic pregnancy, in case of OB/GYN physicians, for example. I personally aware of a couple of incidents where physicians administered the methotrexate in a syringe in a case of ectopic pregnancy lady, and the IV methotrexate splashed into their eyes and caused serious harm to the physician. So it's not a joke. We have to protect ourselves. It could be, it exposes really major hazards in our health when we deal with those medications. You need to update your list when the location, storage, type, or quantities of hazardous material has changed. Our colleagues who work in warehouses, they might not be a part of a healthcare provider, so they will not be aware of the toxicity and hazards of those medications. What if they have dropped a box of methotrexate or hydroxyurea vials on the floor while they are transporting them? Are they aware of the toxicity of those medications when they're going to clean the area? So you have to carry responsibility, especially for pharmacists or healthcare providers who are working in such area. Now let's focus on the facility without chemotherapy services, because they think themselves that they are immune and free from hazards, because, I don't have chemotherapy in my environment, so why should I care? Well, this is not correct, of course, because there are other non-chemotherapy medications that are classified as hazardous. So again, you have to assess the risk and stratify their hazardness. You have to identify and use alternative contaminant strategies and or work practices for specific dosage form of hazardous drug that are not antineoplastic agents. For example, if I am a non-chemotherapy facility, I don't have an oncology patient, but I have OB/GYN patient that they do encounter from time to another ectopic pregnancy. Therefore, you don't have a biological safety cabinet to prepare those medications. We advise, as convenient, to purchase those kind of dosage forms, the pre-filled syringe, where the physician or the nurse, they don't have to withdraw the medication from a vial and then expose themselves to the hazardness of this medication. You just remove the cap and inject the patient with a pre-prepared pre-filled syringe. The use of closed system transfer devices. Pharmacists usually are aware of those devices. We call them CSTD, the closed system transfer devices. And one of the most famous brand is, we call it the Facile. It looks like this one, where if you don't have this IV hood, it absorbs all the vapor. So if you want to withdraw medication in this syringe from this cytotoxic medication, it absorbs the hazardous fumes or vapor as you withdraw the medication. So it does not expose you to the hazardness of those medication as much as you can. So you have to continuously think of measures and precaution and standard measures that are all available under USP Chapter 800 on how to deal with those medications safely. You have to assess different exposure scenarios. As we said, inpatient versus outpatient, physician versus nurses. Some hazardous drug may not pose a significant risk of direct occupational exposure. For example, coated tablet. Why should I care much? I'm not going to grind it. All what I need is just wear an ordinary gloves and touch it with an ordinary gloves. If I'm going to give it directly to the patient. Even for chemotherapy patients, we teach the family sometimes, if they want to give a chemotherapy tablet to their beloved ones, kids, that they have to wear gloves when they deal with those medications. They may pose a risk if the formulations are altered. And here we're talking about crushing tablet or preparation outside a ventilated cabinet. Uncoated tablet may present a risk of exposure from dusty by skin contact, dermatological effect, or inhalation when counted. Excuse me. Counting and pouring should be done carefully. You have to have a dedicated equipment for that. Crushing tablet or opening capsules should be avoided. Ready-made liquid dosage form should be used whenever possible. So you might encounter that they are more costly than the usual dosage form, but they are safer. So we need to do, as I said, an assessment of Fresc. So we have to take into consideration the following factor, but not limited to the type of drug, the dosage form, tablet, capsule, liquid, the route of exposure. If I'm giving it oral versus IV, the packaging itself. Do I need to do manipulation with the dosage form? Cut it, crush it, dissolve it. Different kind of scenarios will have different risk assessment and therefore different precaution measures and protective measures. These are some examples of different institutions, how they deal with hazardous medication. For example, for counting, they have a special dedicated counter equipment or device, which is different from the ordinary equipment, counting device. You cannot mix hazardous medication with non-hazardous medication counting devices. Also for the automatic counters. Also for hospitals that are dealing with robotics, they have different dedicated compartment dedicated for hazardous drug that you cannot mix it with other kind of medications. Another poll questions to give you some rest. What do you think the highest potential of the following risk scenario on workers' exposure in use of the following drugs? We're talking here about the highest potential exposure. A hospital that dispenses a single tablet to a patient. A hospital that has counting, cutting, or crushing of tablets. A hospital that prepares IV doses of an antineoplastic drugs in a biological safety cabinet, or a hospital that prepares extemporaneous solution without biological safety cabinet. Extemporaneous here is manipulating the drug or formulating it from the original dosage form. What are the highest potential risk exposure scenario among the four following scenarios? I'll give you a couple of seconds to read them again. Okay, and the correct answer is letter D. So the hospital that prepare those medications, dissolve them or grind them or cut them without out in the outside air, without a biological safety cabinet that could absorb the fume or the vapor, carries the highest potential for the healthcare workers. You should not prepare those medication in the outside air without a biological safety cabinet. In the old days, when we don't have the biological safety cabinet, I remember in the first organization that I worked with, we used to have a big plastic bag that we put our hands inside, you know, with some, you know, double mask and double glove. But even with those precautions, we are not immune, and we could also expose ourselves to the hazardness of these drugs. Now, for facilities with chemotherapy service, I think the equation is a little bit easier because definitely we have to have a biological safety cabinet. I know facilities without with no chemotherapy service, they don't want to invest in buying the biological safety cabinet. It's a little bit expensive. That's why the exposure might be more serious. But with facilities with chemotherapy service, definitely they will have, inshallah, biological safety cabinet, which is safer. For facilities with chemotherapy preparation and oncology service, you have to train and teach your staff and assist them through a competency practices during the compounding, how to crush, how to dissolve, preparing an ointment. Workers should wear non-permeable gowns and double gloves. We cannot use such gowns. These are permeable. You need to use cytotoxic gowns that, God forbidden, if there is any spill, it protect your body or clothes from the exposure to hazardous drug. Again, you should wear a specific cytotoxic gloves, those with the blue color mostly. Try to avoid the ordinary gloves. This is the biological safety cabinet. We have type B1 and type B2. You found them in pharmacy. We call them ISO class 5 biological safety cabinet, BSC, with 100% exhaust air outside the building. So if you go to the roof of those buildings, you will find a big tunnel that is high above the air in order to exhaust the cytotoxic fume to the outside air. And it has also special precaution and design that is well known to engineers when they design so as not to contaminate the outside environment as well. Storage of those medication, access to all areas where hazardous drugs are stored is limited to specific authorized staff. A method should be present for identifying to personnel those drugs, warning labels. You have to teach the workers on those areas what is the difference between a label that is titled as cytotoxic or hazardous or chemotherapy versus an ordinary label, and how to deal with them. You have to have a method for identifying shipping those cartons to the distribution area. You have to have, of course, a policy or procedure for handling damaged packages. Facilities for storing hazardous drugs are designed to prevent breakage, and you have to have a well-contained method for transporting them safely. This is different kind of labeling in different institution. I took them from a real institution during my visits to hospital, just to share good practices. So you can see, for example, this is an outpatient pharmacy where they don't deal much with, or the risk assessment there is very low. They just put a small label to identify them as hazardous medication. And the example here is diflucan or fluconazole. Just to give a simple instruction to the patient when they deal with those medications, that they have to wear gloves, or if the lady is pregnant, what are the FDA pregnancy category. For in the inpatient setting, you can use such label: chemotherapy, hazardous drug, wear gloves, prime IV tubing. So it's not enough just to put a hazardous drug to the workers. Okay, thank you for telling me this is a hazardous. So what should I do? So some organization use a creative method for putting also the instruction to remind staff on what they need to do. Another kind of labels, they put warning, cytotoxic, and a photo of a baby here, antineoplastic, potential reproductive. So it alerts actually whoever deals with them whenever they see them, and they have to follow the policy, the procedure, the precautions whenever they deal with it. Training is a very important aspect of protecting yourself and your colleagues and your environment when you deal with those medications. Everyone who deals with those medications, whether physician, nurse, or pharmacist, they should receive an education program for staff exposed or utilizing those drugs. And the orientation program should include, I could share this presentation with you. For example, you could use it for providing a quick orientation for your staff, for the new hires, for everyone involved. There should be an annual competency, because every time and then the list of NIOSH gets expanded, or they sometimes remove some of those medication from the list if evidence is proved that it has no potential toxicity. the MSDS, the material safety data sheet, you have to make them always available in the work environment, just in case, God forbidden, any of your colleague or yourself gets exposed to those medication. How should you react if it touches your skin, or if it's splashed into your eyes? What should I do? This is example of a training agenda. It has a didactic overview, definition of hazardous drug, why they are toxic, a history of them. Of course, you need to adjust the theoretical aspect of it according to the level of staff you're working with. The mutagenicity, teratogenicity, carcinogenicity properties, what to do in case of storage, handling, disposal, safe aseptic manipulation. The room itself, it has to be a negative pressure for the biological safety cabinet, correct use of the closed system transfer devices, treatment of exposed personnel, if they get exposed to those medication, or if there is a spill, what should we do, what are the clean up, and you have always to consult your safety officer for dealing with those. If it's a large amount or if it's a small amount, you should not always deal with those medication. You can deal with it or treat it if it's a small spill, but if it's a large spill, you should not come close to it and leave it to the safety officer to clean it using a chemo spill. Compounding personnel of reproductive capability shall confirm in writing that they understand the risk of handling. As a matter of fact, those staff in the reproductive age, or pregnant ladies, or lactating ladies, or in the reproductive age, should be aware and trained very well how to handle those medications. And there should be at the end a competency assessment before those individuals are left to work independently, to ensure that they did understand what has been explained to them and they practiced it safely. This is an example of the personal protective equipment that we use during compounding, administration, spill control, and waste management. You have to ensure that you have such material well stored at your working area. Reporting. In case of any spill, God forbidden, or exposure, you have to report what we call an OVR. It has different names in different institutions in different countries. Incident reporting form, occurrence various reporting form, safety reporting form. And the purpose of it is we need to study why this spill or exposure has happened, so we can develop our system to avoid reoccurrence of the same scenario and to learn from what has happened, but not to blame individual or to throw blame on them. This is example of spill control that should be available in every area, in every location, in every institution where they deal with hazardous drug. As I said, not in the outpatient pharmacy, of course. Why do I need a spill kit in the outpatient pharmacy if I'm dealing with a tablet dosage form? But of course, in the inpatient pharmacy where you have chemotherapy, you have to make sure that you have a good brand of this. It's not just a couple of gloves and the bag, and you put it inside the bag and you claim that it's a spill kit. You have to buy the well-recognized brand. This is an example where material safety data sheet, the MSDS, could be collated and located into different areas. If you open those MSDS, you will find different kind of information related to different kind of drugs and how to deal with them in case if there is a spill of exposure. Some areas, they have an emergency shower in case if the exposure area is wide and broad on the body. And there is an eye wash machine sometimes. Of course, you will not have it, as I said, in the inpatient. Definitely, you need to have one in the warehouse if you have storage of chemotherapy or cytotoxic agent, and you have to train the workers there how to deal with it. You have to test this eye wash machine. Sometimes it stays for a long time without anybody checking their maintenance, and whenever it is in need, it's clogged or not working. So lastly, just to recap, I'm sure you've been bored now of listening to me for the past 1 hour. A quick take-home messages. Safe handling precautions can vary with the activity and the formulation of the drug. Remember the risk assessment. All hazardous drugs, regardless of the formulation, should be labeled as such to prevent improper handling and to give instruction to the patient in case of they carry certain toxicity during pregnancy. Proper training is an essential component for handling and management of hazardous drug. Always follow recommendations included in the manufacturer's safety data sheets of the drug package inserts, and develop your own list, your own precautions based on your resources, based on your context. So for those hospitals that are not well resourced, for example, that they cannot afford, say, to have the eye wash station. I know that they have used a normal saline bottle that they are change it on a daily basis in a special apparatus where you can squeeze it and it can splash into your eyes in case of hazardness. This is a kind of just remember that hazardous drug is not just in oncology organization institution. These are example of different kind of chemotherapy agents that are used for non-oncologic purposes. For example, cyclophosphamide is used in rheumatology, cyclosporine in transplant, ganciclovir in infectious disease, methotrexate in OB/GYN. So again, if you are not working in an oncology service, it does not mean that you are safe and immune from other kind of aspects of the toxicity of those medication. As a matter of fact, I think the risk is higher in those institutions because staff are not expecting that they are dealing with hazardous drugs. Last poll question for today. And hopefully that inshallah you get the value and you can answer it correctly this time. Healthcare workers occupationally exposed to hazardous drug may experience or suffer from skin rash, infertility, cancer, do not experience major side effects as they are exposed only to small individual doses of a drug. Is it all of the above? Is it A, B, and C? Anyone would like to answer over the mic?
E.
Again, please. Any answer? Okay, it's F. It's A, B, and C.
All of it.
It's not all because D is, it says do not experience major side effect.
Yes.
Well, when we say if healthcare worker got cancer because of dealing with this drug, it is a major side effect indeed.
Okay.
So hazardous is always there. NIOSH state that, sorry, this is, I think is taking my slide. I need to put it away just to read the statement for you. NIOSH state that measurable concentration of some hazardous drug have been documented in the urine of healthcare worker who prepared or administered them, even after safety precaution had been employed. This is not to freak you out, لا سمح الله يعني, بس as matter as we can, we have to take all precautions to protect ourselves and our loved one. These are the references if you need to get more information or access either from NIOSH, SIBAHI, GCI, or even CDC to give more information about that. That's all from my side. Thank you so much for listening and being attentive, and I hope that what I have said added value to you, and it will be reflected into your practice, and please stay safe. Dr. Abul Futuh, if you would like to open the mic for any question, or if any question over the chat, it's my pleasure to listen and answer.
شكرا جزيلا لك يا دكتورة سوزان على المحاضرة القيمة ديت، وطبعا شكرا على حضورك معنا في المؤتمر ومشاركتك بالمعلومات القيمة. وبنفتح النقاش لو في أي حد عنده سؤال لدكتورة سوزان عايز يسأل على أي حاجة كبيرة، اتفضل على طول يفتح المايك ويسأل. اوكي.
أنا شايفة الإجابات على الشات ما شاء الله يعني معظمها الرايت أنسر.
هما بسم الله ما شاء الله اوير يعني، وطبعا بيعملوا ريفريشمنت للمعلومات بتاعتهم مع حضرتك طبعا. بس
ربنا ينفع
في اي
فيكم إن
حد
شاء
عايز
الله.
يسال الدكتوره سوزان في حاجه؟ طبعا فرصه معانا يعني، الدكتوره سوزان غنيه عن التعريف يعني.
الله يخليك.
ما فيش اي اسئله عن الميديكيشن مانجمنت ان جنرال يعني، طبعا اكيد هتبقى اكسبتد تجاوبها يعني. لو في حد عنده كونسيرنز او اي حاجه بتقابله في البراكتس بتاعته في الامبلمنتيشن لاي حاجه. لا
في
حضرتك
سؤال
افتح
على
المايك.
الشات.
ماشي اوكي، افتح المايك حضرتك، او اللي عايز يسال يفتح المايك ويسال. اوكي. who deal with، في سؤال بيقول لك who deal with hazardous chemical.
hazardous drug or chemicals. الكيميكالز طبعا هم موستلي الهاوس كيبرز طبعا، عشان كده احنا لازم برضو نعطيهم تعريف بالهازاردنس تبعت هذه الكيميكالز، او حتى الفارماسيست بيستخدموا احيانا الكيميكالز لتنظيف اللامينار فلوهود، غرفة التحضيرات الوريدية. فبرضو لها درجة توكسيسيتي معينة كمان، ومكتوبة كلها بالاس دي اس بتكون موجودة. فبيفور يو تاتش اني اوف ذوس ايجنتس لازم نقرأ يعني بدقة البريكوشنز الموجودة على البامفلت الداخلية والتعامل معها.
السلام عليكم دكتوره هبه، انت ليكي اكتر من سؤال، ممكن تفتح المايك بس وتبقى في نقاش انتراكتيف مع الدكتوره يعني، وأكيد هيكون افضل يعني.
تفضلي دكتورة هبة.
دكتوره هبه سعيد، اتفضلي.
مساء الخير.
مساء
هو أنا
النور.
آسفة، بس أنا كتبت السؤال على مرتين فاتفهم غلط. طبعا شكرا جدا على محاضرة حضرتك القيمة جدا.
شكرا لله.
السؤال بتاعي ايه الاناليسيز، كيميكال كلينيكال اناليسيز اللي انا اقدر اعملها للستاف اللي بيتعامل مع الهازاردس دراجز، تحاليل، اشعاعات، يعني عشان ابقى بمونيتور الستاف ده سواء فارماسيست او نيرسز. هل كده سؤالي واضح لحضرتك يا فندم؟
شكرا على سؤالك. نعم شكرا.
أوكي.
طبعا هو ما جرى العرف مثلا، او ما في ايفيدنس بيقول لك انه زي مثلا الراديولوجي، الناس اللي بتشتغل في الراديولوجي انه كل 3 شهور عندهم الجهاز تبعهم هذا التي ال دي لازم يروح ينعمل له تيست ويرجع. ما في ايفيدنس بيقول لك انه الستاف اللي بيشتغلوا في الهازاردس كيميكال لازم نعمل لهم تحاليل معينة أو حاجة، إلا لا سمح الله لو حصل لهم بنكتشر أو انجكشن أو حصل في سبلاش معين. هنا لازم يروحوا يراجعوا الفاميلي ميديسن أو الامبلوي هيلث كلينيك، والدكتور هناك بيدرس درجة الإكسبوجر عشان يطلب تحاليل معينة. لكن ما في حاجة جرت العادة أنها تكون ريجولر بشكل ريجولر. وما تقلقيش يعني، هو الواحد طبعا أنا اشتغلت في الكانسر سنتر لمدة يعني انكولوجي فارماسيست فور يعني حوالي 6 سنوات، وكنت حتى وأنا حامل يعني أحيانا بحضر. فما تقلقوش يعني، هي فقط المحاضرة لرفع درجة الأويرنس على الميديكيشن هذه، لكن في حالة إنه اتخذنا البريكوشنز الكاملة بإذن الله بوجود بيولوجيكال سيفتي كابينت، ويعني ما استهترنا بالموضوع، إن شاء الله إنه الإكسبوجر يعني حيكون بدرجة معدومة بإذن الله تعالى.
شكرا جزيلا يا دكتوره. في اي
شكرا
حد
جدا
ليه سؤال؟
لحضرتك،
شكرا
شكرا جدا يا
ليكي.
فندم.
شكرا.
شكرا
السلام
دكتوره
عليكم
هبه.
ورحمة الله.
عليكم السلام. في
عليكم
اي
السلام.
حد ليه سؤال تاني للدكتوره؟
أيوة يا فندم لو سمحت.
اتفضلي.
تفضلي.
لو سمحتي البوتلز أو الحاجات اللي بتبقى containing الكيميكالز بيكون إيه مصيرها؟ يعني إزاي بنتعامل مع الويست بتاعتها؟
نعم تقصدي حضرتك بعد ما نسحب منها الدواء؟
أيوة.
طبعا ده في حال في الصيدلية طبعا. حضرتك لو تكوني في المستشفى، طبعا احنا عندنا في هنا في السعودية في ستاندرد كامل على موضوع الويست مانجمنت، وفي تشابتر كامل على هذا الموضوع، وبنعمله بالتعاون مع السيفتي اوفيسر، لانه هم كمان شيرد معانا في الريسبونسبيلتي على هذا الموضوع. ففي كلير انستراكشن فين البوتلز هذه بتنحط في بنز لونها أصفر مكتوب عليها إنها hazardous material مثلا، أو في باجز لونها أصفر زي فكرة البلاد برودكت، لما أكياس الدم لما بتخلص وبعدين بتنجمع من الهاوس كيبر، وبعدين بتترمى عن طريق شركة متخصصة اللي بتعملها انسنريشن أو بتعملها ويست مانجمنت متخصص عشان ما تضرش الانفايرمنت. فبيكون في عقد مع الشركات هذه اللي هي متخصصة في موضوع الويستنج اوف البيولوجيكال أو الهازاردس أو البيوكيميكال ايجنتس.
يعني بتروح محرقة تقريبا يعني.
نعم عندهم طريقة خاصة، بس ديفينتلي ما بتترماش في أكياس الله يكرمك الجاربج العادية اللي هي لونها أسود أو أزرق. هي متخصصة ومعلمة وليها ليبل خاص إنها فور hazardous drug.
متشكرة قوي.
العفو.
جزاك الله خير.
الله يبارك فيك. في سؤال آخر؟
في أي حد عنده سؤال تاني؟ يتفضل على طول يفتح المايك ويتكلم. يا جماعة محدش عايز يسأل؟
إن شاء الله إنه المسج يعني واضحة يا دكتور.
بسم الله. بالنسبة للهازاردس ميديكيشن، بسم الله ما شاء الله يا دكتورة، يعني أنت وضحتيها. بس في أي حاجة إن جنرال حتى في الميديكيشن مانجمنت مش شرط الهازاردس. طبعا
صحيح.
مؤكد الدكتورة.
أنا الإيميل أنت شايف دكتور هنا مكتوب.
أيوة.
يسعدني يعني أتلقى أي سؤال على الإيميل الخاص يعني في أي وقت. يعني تفضلوا في أي وقت يعني.
دي يعني الدكتورة سوزان بإذن الله قدر الله تساعد أي حد محتاج أي شيء. طبعا ده دايما هي معودانا على كده يعني.
الله يخليك يا رب.
الله
واجبي.
يخليك. خلاص مفيش أي حاجة، نقفل النقاش يعني. ها يا جماعة، مفيش أي حد ما قابله أي مشكلة في الميديكيشن مانجمنت، في الإمبلمنتيشن بتاع الستاندرد، في إزاي، في أي شيء؟ بسم الله ما شاء
دكتور
الله.
أنا حبعت لك البرزنتيشن.
اوكي.
فيل فري انك تشيرت يعني على الفيس او بالطريقه اللي تشوفها حضرتك مناسبه.
خلاص باذن الله هنزلها على البيج بتاعت الموقع، خلاص بحيث تبقى افيلابل لكل الناس اللي هم اللي عايز يشوفها وينزلها. اوكي. عموما قبل ما نختم، شكرا جزيلا يا دكتوره سوزان على وقتك اللي انت اديته لنا وعلى المعلومات القيمه اللي انت شرحتيها النهارده. باذن الله ربنا يجعلها كده في ميزان حسناتك. شكرا جزيلا لكل الناس اللي حضروا معانا النهارده. بفكركم بس احنا بكره في ريست، مفيش محاضرات، هنبدا من بعدها. وشكرا طبعا لكل الناس اللي حضروا واللي هم لغايه دلوقتي بيتواصلوا عشان يحضروا الايفنت. وباذن الله كده نبقى دايما تحت يعني عند حسن الظن بيكم او فيكم او فينا، يعني اللي انتم تبقوا فعلا احنا بنقدم لكم حاجه تقدر تفيد الناس. شكرا جزيلا لكم وشكرا جزيلا دكتوره سوزان.
شكرا جزيلا. السلام عليكم.
السلام عليكم.